Hypertension, Essential Ronald N. Adler, M.D., FOF Jeremy Golding, M.D., FOF Basics Description Essential hypertension, HTN, is HTN without an identifiable cause. It is also known as primary HTN and benign HTN. Although its importance as a risk factor for cardiovascular and other morbidity and mortality is well established, there is significant and increasing controversy regarding recommended thresholds for diagnosis and treatment. HTN is defined, Joint National Committee JNC8, as greater than or equal to 2 elevated blood pressures, BPS, 1. Age 60 years, systolic BP, SBP, greater than or equal to 140 mmHg and/or diastolic BP, DBP, greater than or equal to 90 mmHg at greater than or equal to 2 visits. Age greater than or equal to 60 years, SBP greater than or equal to 150 mmHg and/or DBP greater than or equal to 90 mmHg at greater than or equal to 2 visits. With diabetes or chronic kidney disease, CKD SBP greater than or equal to 140 and/or DBP greater than or equal to 90 mmHg. Synonym, S. Benign, chronic, idiopathic, familial, or genetic HTN. High BP geriatric considerations. Isolated systolic HTN is common. Therapy has been shown to be effective and beneficial at preventing stroke and cardiovascular morbidity and all-cause mortality. 2a. Although target SBP for seniors is higher than in younger patients, 150 mmHg systolic, and adverse reactions to medications are more frequent. The benefit of therapy has been conclusively demonstrated in older patients for SBP greater than or equal to 160 mmHg. A target of 140/90 mmHg may be appropriate for higher risk individuals. 2a. Very elderly patients may be at particularly high risk of adverse events associated with pharmaceutical treatment of HTN. Strongest evidence of benefit has been shown with use of thiazide diuretics. Pediatric considerations measure BP during routine exams beginning at age 3 years. Defined as SBP or DBP greater than or equal to 95th percentile on repeated measurements pre-HTN, SBP or DBP between 90th and 95th percentile. Pregnancy considerations. Elevated BP during pregnancy may represent chronic HTN, pregnancy-induced HTN, or preeclampsia. Angiotensin-converting enzyme, ACE, inhibitors and angiotensin II receptor blockers, ARBs, are contraindicated. Maternal and fetal mortality are reduced with treatment of severe HTN. Evidence is not clear for treatment of mild HTN. See topic preeclampsia and eclampsia, toxemia of pregnancy. Preferred agents, labetalol, nifedipine, methyldopa, or hydralazine. Epidemiology. Incidence and prevalence is higher among men. Prevalence depending on the definition used. 30–46% of adults in the United States have HTN. Etiology and pathophysiology. 90% of cases of HTN have no identified cause. For differential diagnosis and causes of secondary HTN, see hypertension, secondary and resistant. Genetics. BP levels are strongly familial, but no clear genetic pattern exists. Familial risk for cardiovascular diseases, CVDs, should be considered. Risk factors. Family history, obesity, alcohol use, excess dietary sodium, stress, physical inactivity, tobacco use, insulin resistance, obstructive sleep apnea, OSA. Diagnosis. Despite more aggressive guidelines issued by the ACC/AHA in 2017, many experts consider recommendations from JNC8, 1A to retain primacy. Critics of the ACC/AHA guidelines note multiple methodologic concerns, especially the fact the guidelines were heavily influenced by the findings of SPRINT, which was conducted in a relatively high-risk population and therefore less applicable to many patients seen in primary care. Using thresholds of 130/80 mmHg, as endorsed by AHA/ACC, compared to JNC8 would result in the diagnosis of and treatment for HTN of millions more people, with unclear benefits and likely harm. Therefore, This chapter uses JNC8 as its basis but focuses on recommendations that are relevant regardless applied. These include diagnostic considerations and using assessment of overall CV risk to guide treatment decisions. History: HTN is asymptomatic except in extreme cases or after related cardiovascular complications develop. Headache can be seen with higher BP, often present on awakening and occipital in location. Physical exam: body mass index, BMI, waist circumference, BP in both arms. See below for correct technique essential to accurate diagnosis and treatment. Complete cardiac and peripheral pulse exam. Compare radial and femoral pulse for differences in volume and timing. Evaluation for aortic coarctation, especially in young persons. Subclavian stenosis. Fundoscopic exam for arteriolar narrowing, AV compression, hemorrhages, exudates, and papilledema. Differential diagnosis: secondary HTN. Because of the low incidence of reversible secondary HTN, special tests should be considered only if the history, physical exam, or basic laboratory evaluation suggest a higher likelihood. Also consider for patients who prove non-responsive to treatment. See hypertension, secondary and resistant. White coat HTN, elevation of BP in office setting and normal BP outside office. Masked HTN, elevated BP at home and normal BP in office. Diagnostic tests and interpretation: incorrect BP determination is a common cause of overdiagnosis. Home blood pressure measurements are better associated with hard outcomes than office values, and also help to mitigate the errors of clinic measurement. Home BP measurement and monitoring should be encouraged. Alert measuring BP, caffeine, exercise, and smoking avoided greater than 30 minutes before measurement. Patient seated quietly for at least 5 minutes with feet on floor. Patient's arms supported at heart level. Correct cuff size. Deflate cuff slowly or use an automated device. Average of 2 or more measurements. Avoid rounding results. May leave patient alone to obtain in-office readings using an automated or patient-activated cuff. A diagnosis of HTN should be made when age 60 years, SBP greater than or equal to 140 mmHg and/or DBP greater than or equal to 90 mmHg at greater than or equal to 2 visits. Age greater than or equal to 60 years, SBP greater than or equal to 150 mmHg and/or DBP greater than or equal to 90 mmHg at greater than or equal to 2 visits. Age greater than or equal to 60 years with CKD or diabetes, SBP greater than or equal to 140 mmHg and/or DBP greater than or equal to 90 mmHg at greater than or equal to 2 visits. Initial tests, lab, imaging, hemoglobin or hematocrit or complete blood count. Complete urinalysis may reveal proteinuria, hematuria/nephritis, potassium, calcium, creatinine, and uric acid. Lipid panel, total, high-density lipoprotein, low-density lipoprotein, triglyceride, fasting blood glucose or hemoglobin A1c ECG to evaluate possible presence of left ventricular hypertrophy, LVH, or rhythm abnormalities. Follow-up tests and special considerations. Special tests only if suggested by history, physical, or labs. Consider possibility of sleep apnea with high BMI. Ambulatory, 24-hour, BP monitoring if white coat HTN is suspected, episodic HTN, or autonomic dysfunction. UK and US guidelines recognize the importance of confirmation of hypertension using home or ambulatory, 24-hour, blood pressure measurement. Ambulatory measurement may be especially helpful if there is suspected autonomic dysfunction. CV risk assessment should be performed. The AHA/ACC risk tool likely significantly overestimates risk in many patients, 50% or more, especially in multi-ethnic and older patients. Others have used a definition of low risk that excludes patients with a history of CVD, diabetes mellitus, CKD, or familial hypercholesterolemia of premature coronary artery disease. Treatment general measures. The treatment discussed follows JNC8 guidelines. Recent systematic reviews and meta-analyses of randomized trials do not support recommendations for lower than standard targets for the average risk population. Potential harms of therapy must be weighed against the potential benefits. Treatment goals. Age 60 years. SBP greater than or equal to 140 mmHg and/or DBP greater than or equal to 90 mmHg. Age greater than or equal to 60 years. SBP greater than or equal to 150 mmHg and/or DBP greater than or equal to 90 mmHg. Age greater than or equal to 60 years with CKD or diabetes. SBP greater than or equal to 140 mmHg and/or DBP greater than or equal to 90 mmHg. More aggressive treatment may be considered in patients meeting enrollment criteria for SPRINT because aggressive treatment does show improvement in outcomes, but 61 non-diabetic patients would need to be treated, NNT, for 3 years to a goal of SBP 120 mmHg to prevent a major cardiovascular outcome, and 90 mmHg to prevent one death. More intensive therapy may be considered for certain high-risk individuals. Even in secondary prevention, no firm conclusions can yet be drawn regarding the comparative effectiveness of intensive versus standard therapy. Individual treatment goals should be jointly established with patients after discussion of the anticipated potential benefits and harms. Shared decision-making. 1. 2. Recommend lifestyle improvements, including diet, exercise, and reducing or eliminating tobacco/alcohol. Benefit of pharmacologic treatment of low-risk patients with Class I HTN, SBP 140 to 150 mmHg, DBP 90 to 99 mmHg, remains uncertain, with harms including syncope, kidney injury, and electrolyte abnormalities. Individualized decisions. Treating patients age 60 years or with CKD or diabetes to lower than standard BP targets, 140/90 mmHg, does not appear to further reduce mortality or morbidity. Individualize goal BP based on risk factors and patient preferences. A target SBP at or just below 150 mmHg in patients greater than 60 years of age is acceptable in the general population. 1a. The majority of treatment benefit is attained by lowering high systolic pressures to lower pressures, e.g., from 190 mmHg to 150 mmHg, as compared with the benefit of lowering from 150 mmHg to 136 mmHg. Striving for small additional drops in BP by adding third, fourth, or fifth medications to achieve a target is less clinically beneficial and more likely to cause adverse effects. Lower than standard DBP targets are not associated with decreased morbidity/mortality. Medication. Multiple drugs at submaximal dose may achieve target BP with fewer side effects. In patients on greater than one medication, divide between morning and nighttime for better 24-hour antihypertensive effect. Sequential monotherapy attempts should be tried with different classes because individual responses vary. Many patients will require multiple medications. For initial monotherapy, choose from one of 4 classes of medications: ACE inhibitors, ARBs, calcium channel blockers, CCBs, or diuretics. 1a. Thiazide diuretics or CCB preferred as first line in the general black population. Chlorthalidone has a longer half-life than hydrochlorothiazide, HCDZ, and is the preferred diuretic based on established trial evidence of benefit. It is a more potent antihypertensive than HCDZ. If concomitant conditions, choose first-line agent based on comorbidity. Beta blockers had been strongly recommended until recent meta-analyses. Atenolol may be particularly ineffective in reducing adverse outcomes of HTN, except in patients with left ventricle hypertrophy undergoing dialysis. Beta blockers often benefit patients with ischemic heart disease, atrial fibrillation, CHF, migraine, and patients with history of ST segment elevation, myocardial infarction, STEMI. ACE inhibitors should be used in patients with diabetes, proteinuria, atrial fibrillation, or heart failure with reduced ejection fraction, HFrEF, but not in pregnancy. Alpha-adrenergic blockers are not a first choice for monotherapy but remain as second line after combination therapy of first-line agents, might benefit males with benign prostatic hypertrophy, BPH. CCB could be considered in patients with isolated systolic HTN, atherosclerosis, angina, migraine, or asthma. Well documented to reduce risk of stroke. First-line thiazide diuretics may not be effective with creatinine clearance 30. Chlorthalidone, 12.5 to 25 mg/day, longer half-life and more potent than hydrochlorothiazide but causes more hyponatremia and hypokalemia. Strongest evidence base for this medication: hydrochlorothiazide, 12.5 to 50 mg/day, and dipamide, 1.25 to 2.5 mg/day. Metolazone, 2.5 to 5 mg daily, is more effective in patients with impaired renal function than other thiazides, but outcome studies lacking. ACE inhibitors: lisinopril, 5 to 40 mg/day, enalapril, 5 to 40 mg/day, ramipril, 2.5 to 20 mg/day, benazepril, 10 to 40 mg/day, CCB. amlodipine, 2.5 to 10 mg/day, nifedipine, sustained release 30 to 90 mg/day, diltiazem CD, 180 to 360 mg/day, verapamil, sustained release 120 to 480 mg/day, ARBs. Losartan, 25 to 100 mg in 1 or 2 doses, has unique but modest uricose-uric effect. Valsartan, 80 to 320 mg daily. Irbesartan, 75 to 300 mg daily. Candesartan, 4 to 32 mg daily. Renin inhibitor, aliskiren, 150 to 300 mg daily. Contraindications: thiazide diuretics may worsen gout. Beta blockers, relative, in asthma, heart block, diabetes, and peripheral vascular disease, probably should be avoided in patients with metabolic syndrome or insulin-requiring diabetes. Diltiazem or verapamil, do not use with systolic dysfunction or heart block. Amlodipine may cause peripheral edema. Second line before escalating therapy, ensure that patient is adherent to prescribed regimen. Many may be combined. Choose additional medications with complementary effects, i.e., ACE inhibitors/ARBs with diuretic or a vasodilator with a diuretic or beta blocker. Don't combine ACE inhibitor and ARB. Medication refractory HTN, see secondary and resistant hypertension. Spironolactone 25 to 100 mg/day or eplerenone 50 mg once to twice daily are especially effective. Centrally acting alpha-2 agonists, clonidine 0.1 to 1.2 mg bid or weekly patch 0.1 to 0.3 mg/day, guanfacine 1 to 3 mg daily, or methyldopa 250 to 2000 mg bid. Alpha adrenergic antagonists, prazosin 1 to 10 mg bid, terazosin 1 to 20 mg/day, or doxazosin 1 to 16 mg/day. Vasodilators: hydralazine, 10 to 25 mg QID, risk of tachycardia, so generally combined with beta blocker, also drug-induced systemic lupus erythematosus, SLE, minoxidil, rarely used due to adverse effects, may be more effective than other medications in renal failure and refractory HTN. Metolazone and loop diuretics may be used with more severe renal impairment, but outcomes data are absent. Loop diuretics, for volume overload: furosemide 20 to 320 mg/day or bumetanide 0.5 to 2 mg/day. K+ sparing diuretics in patients with hypokalemia while taking thiazides, amiloride 5 to 10 mg/day or triamterene 50 to 150 mg/day. Complementary and alternative medicine biofeedback and relaxation exercise. Dietary supplements such as garlic have been suggested for lowering BP, but evidence is lacking. Ongoing care follow-up recommendations: patient monitoring, re-evaluate patients Q36MO until stable and then Q612MO. Consider use of home BP self-monitoring. Quality of life issues including sexual function should be considered. Poor medication adherence is a leading cause of apparent medication failure. At least annual creatinine and potassium for patients on diuretics, ACE inhibitors, and ARBs diet. 20% of patients will respond to reduced salt diet, 100 mol/day, 6 grams NaCl or 2.4 grams Na. Consider dietary approaches to stop HTN. Diet. http://www.nhlby.nih.gov/files/docs/public/heart/HBP_low.pdf. Limit alcohol consumption to 1 ounce/day. Patient Education Council for Aerobic Exercise 5 days a week. Complications: heart failure, renal failure, LVH, myocardial infarction, retinal hemorrhage, stroke, hypertensive heart disease, drug side effects, erectile dysfunction. Reference